So hopefully we'll do a few cases of COVID-19 and really just teaching pearls for 5 minutes or less. Okay, so let's do this first question. 41-year-old man with bilateral pulmonary embolus, saddle embolus. As you can see right here, he was actually symptomatic for 3 weeks. He came into the emergency room just with an increase in shortness of breath, saturating 98% of room air. He has obvious infiltrates in the lung parenchyma, bilateral. This is pretty extensive, but he was relatively not too symptomatic. He had inflammatory markers that were elevated. What's the next best step? Local liquid heparin, intravenous TPA, intraarterial TPA, heparin drip, surgical thrombectomy. We're going to discuss pulmonary thrombosis and COVID-19. So D-dimer is elevated in this patient, 11.46. You can see it went down. Ferritin actually peaked on the third day. CRP was sky high, 140. Again, he was not coughing, wheezing, had some shortness of breath, which is why he came in. His ejection fraction was normal on the echocardiogram. He was treated on day 1 with, I won't give away the answer, but he was treated with cytomegil and tocilizumab and remdesivir, as well as convalescent plasma. It shows you how far we have gotten. From the first week, we were with Plaquenil, Kaletra, protocol, and Plaquenil, Kaletra, and maybe tocilizumab. And now it's basically tocilizumab, steroids, remdesivir, plasma, and anticoagulants, as we'll discuss. So I'm really surprised how we haven't really focused on the autopsy studies, but they should give you the answer, and we should be talking about these studies more. And this is an article from Annals of Internal Medicine. I find these articles more valuable than some of the treatment articles that go up and down. So anyway, pulmonary arterial thrombosis, clinical pathologic case series, 11 autopsy patients, 80s and 70s. Look at the risk factors that they looked at: arterial hypertension, diabetes. Most of the patients with hypertension. Now, remember that hypertension and diabetes are also risk factors for venous thromboembolism. And D-dimer was elevated most of the time. Fibrinogen levels were elevated. Pulmonary artery thrombosis, out of the 11 autopsies of COVID pneumonia deaths, were 11 times they found pulmonary artery thrombosis. Pneumonia, interestingly enough, was only in roughly half of the autopsies. Here is a pulmonary artery filled with a blood vessel, pulmonary artery filled with a blood clot. You see here a small pulmonary artery obliterated by a thrombus. Here is interesting, you see the pulmonary artery thrombosis with pneumonia nearby. Here you can see a very active capillary endothelium, and then the microthrombi of these small capillary pulmonary vessels. So it happens in the bigger vessels and it happens in the smaller vessels. And then you have the New England Journal of Medicine autopsy report for 7 patients, and basically what they see is 3 different things. They see this very perivascular lymphocytic infiltrate of the alveolus. They see this capillary endothelium with microthrombi. They also see this thing, what they call intersective angiogenesis. Basically, this is the capillary endothelial layer. This is normal. This is what it looks like under electron microscopy of a COVID patient, because it's just, the vessels are being are built in an abnormal fashion, not organized. That's called intersective angiogenesis. The 3 things they mention is endothelial cell membrane disruption, microangiopathy, and intersective angiogenesis. If you look at chest guidelines just from last month, I was actually surprised to see that in critically ill patients, we suggest just using standard dose. They would not come out and recommend using higher doses, which I believe was a mistake. And Mount Sinai, even a month prior to that, they were admitting patients with severe COVID and putting them on heparin drips. They were even considering TPA protocol. I do believe that they amended this thereafter because they were having some bleeding complications. But at the very least, to double the dose of the prophylaxis would be appropriate. And in the same hospital system in 2,700 patients in outside the health system in New York City. Valentin Fuster, a cardiologist, and Jack published that in-hospital mortality was about a third of what it would be like in patients mechanically ventilated if they were on mechanical ventilation. Pretty remarkable numbers. They admit that, there is some confounding observational nature, but systemic anticoagulation is associated with improved outcomes among patients hospitalized with COVID-19. In covidprotocols.org, which I frequently look at because they have great sources and guidance, for ICU patients and post-ICU patients, they actually recommend higher dosing. So standard dosing is 40 milligrams a day for creatinine clearance greater than 30. It's 40 milligrams BID now in their recommendations, so they go for it. So there's also an article called Immune Mechanisms. I like the term pulmonary intravascular coagulopathy. This is in Lancet Rheumatology. Fascinating. They basically look at intrapulmonary hemophagocytosis secondary to microhemorrhage, secondary to vascular damage, linked to inflammation. So basically you get vascular damage that's linked to inflammation or infection. And then you have macrophages eating up normal cells and destroying some of the alveoli. It's an interesting concept here. It does look very similar to this disease of hemophagocytic lymphohistiocytosis, especially with the high ferritin, but they're calling it pulmonary intravascular coagulopathy. And if you look at what's happening is you have pro-inflammatory cytokines, procoagulant factors causing thrombosis of the pulmonary vessels, but not only the veins, also the arteries. So it's all over the place. And you could have distal emboli, proximal emboli, but it's a really mediated by inflammation. That's why it makes sense that we gave the patient tocilizumab and steroids at the same time, gave him full dose anticoagulation, which you'll see. And the other thing they point out is that you usually get diffuse alveolar damage in coronavirus, whereas in regular bronchopneumonia, only part of the lung would be infected and affected. In this disease, it really affects the whole pulmonary arterial bed because the lymphocytes, the type 2 pneumocytes have these ACE2 receptors, which is where the coronavirus infects. So very interesting article worth reading. 41-year-old man with bilateral pulmonary embolus, saddle embolus. So what should you do? So IV TPA would probably cause bleeding in this patient. Intraarterial TPA, again, this is a different population and they could hemorrhage. So I'd be careful with that, heparin drip. And we would give potentially, but if we have a low molecular weight heparin, that would be better. Surgical thrombectomy, again, putting the patient on cardiopulmonary bypass or ECMO also is associated with an increased risk of hemorrhages. And so the answer is low molecular weight heparin. Thanks for listening and enjoy.